this week on the BackTable podcast.
One thing that I was thinking of asking you earlier, the concept or the thought of like biofilms. And so like a patient having a tube, let's say it's been there for a while, maybe, over a year, longer than it should. And the patient still has eustachian tube dysfunction, still needs a tube. Do you ever, exchange it out? Or let's say, this is a common example. Patients had bilateral tubes. One tube has extruded. The other tube is still there. It's been there for like maybe over a year. It's fine. When you're going to the OR anyway, because you're going to put a tube in the other ear. So do you need to replace that tube with a new tube because it's an old tube?
Yeah. Those are great. Those are great questions. Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT, and we bring you the best and brightest in the field with the hope that you can take something from our show to your practice. Our next partner has a product I use literally every day. I started taking AG1 because I just wanted to see what the hype was about. So what is this stuff? With one delicious scoop of AG1, you're absorbing 75 high-quality vitamins, minerals, whole food-sourced superfoods, probiotics, and adaptogens, whatever those are, to help you start your day right. This special blend of ingredients supports your gut health, your nervous system, your immune system, your energy, recovery, focus, and aging. All the things. I take AG1 in the mornings, right when I'm walking out the door. I put it in about 8 to 10 ounces of water. I put 2 or 3 cubes of ice in it, and then the 1 scoop of the AGs, shake it up, and I'm ready to go and drink it on my way to work. AG1 benefits my lifestyle in the way that it gives me energy. It's very simple, and I can't always prepare every meal and feel like I'm always getting a well-balanced diet or getting all my vitamins and nutrients in. So it's something that I don't even have to think about. It has a bit of a tropical, slightly metallic taste at the end, but it's quite refreshing, especially when taken very cold. We do take AGs when we travel. It comes in these little travel packets, and you can just get a little bottle of water, throw the packet in, shake it up, and it, again, is something that when you have on you when you're traveling, you don't have to worry about feeling that you aren't getting all the nutrients that you need for that day. AG1 is a small micro habit with big benefits. It's one thing you can do every single day to take great care of yourself. Athletic Greens is going to give you a free 1-year supply of immune-supporting vitamin D and 5 free travel packs with your first purchase. All you have to do is visit athleticgreens.com/BackTable ENT. Again, that's athleticgreens.com/BackTable ENT to take ownership of your health and pick up the ultimate daily nutritional insurance. My name is Gopi Shah, and I'm a pediatric ENT. And I'm here today with my mamacita partner in crime, Ashley Agan.
What's up? I'm a general ENT, and I'm always happy to be across the mic, whether it be in person or virtually, from my dear Gopi, dearest friend, co-host.
Well, I've called you mamacita even before the baby because, you're to me, you're my little mama. My little hot mama before, and you still are, even now with a baby
I'm
in
just
tow.
a tired mama now, but it's amazing. It's amazing. Baby's doing great and growing like a weed, so it's pretty cool to watch her change and develop. She's 4 months now, 4 months yesterday, so
she is super
cool.
cute with the best laugh, the best little chuckle.
Those chuckles and giggles, it's the best, absolutely the best. So pretty cool. What are we talking about today?
We are talking about something very exciting, the management of ear tubes. Now, it is something that's very, very practical. And no matter if you're, super uber specialized ENT to a general ENT, city, private, group, academic, you're going to deal with ear tubes.
Mm-hmm. Yeah, that definitely comes up a lot for everybody.
Yeah. So, whether they're clogged, whether they're draining, whether the tube hasn't fallen out, there's lots of little things in clinic. So I guess I wanted to ask you for your clogged ear tubes. The let's say it's the 2-year-old that comes in, had tubes, whether it was 6 weeks ago or maybe it was 6 months ago, it's a tube check. And one of the tubes is clogged. You got your hearing test, let's say it's normal audio. And it's either maybe that type A temp or a small volume B temp. Tube looks good, but it's clogged.
But looks clogged.
Yeah.
But the hearing's normal?
But the hearing's good.
So in a kid, I would probably not do much. Okay, it depends. So if the parent says, we've been doing great, no issues, no ear infections, speech development's fine, school is fine, audiogram shows normal hearing, and, the tube just looks clogged. I'm like, I'll probably leave it alone. I'll probably just say, like, let's just watch it. It's not technically really giving you any issues, right? In an adult that will let me really examine and, mess with their ear, I'll probably go in there and try to pick it out just because I feel like if it's going to be there, I'd like for it to be working. We put it in there for a reason. But kids are a little bit different, or the kids are a lot different. And so, I wouldn't want to traumatize or create, sometimes less is more. But when, if there's issues, obviously you might feel differently. So if they're having recurrent ear infections and you really want that tube to be open and working, then I would want to do something. I would probably start with just starting drops to see if it would to dissolve away that clog. Would probably use just like Floxin drops, have them, do it twice a day, pump the tragus to make sure the drops are really getting all the way down there, and then kind of see them back in a short amount of time to kind of see if it's working at all. Yeah. I don't know. What do you do?
I agree. I think if they're, asymptomatic and hearing's good, speech is good, they're not having issues with ear infections, sometimes I'll just watch them, and I'll also give the family an option if we want to try some Floxin, Ciprodex. And you're right. We do have to be a little bit more aggressive when there are issues. Sometimes I will do a little, it depends on the family and kind of what the parent is up for. Every once in a while, I'll have them try a little diluted peroxide at home. So like I'll have them do half distilled or bottled water and half peroxide, put it in like a little cup, like a tablespoon each, and then get a dropper and do like, a couple of drops, 3-4 drops from the Tragus, and then chase it with Ciprodex. And I tell the family if the child starts to cry, hopefully that means that the tube is, open, because the peroxide's going to irritate the middle ear usually. And I might have them do that for about 3 to 5 days unless the child starts to cry before, and then just switch over to regular Ciprodex or Floxin for another 3 days, and then see them back and see how they look. But again, it depends on, and I'll tell the family, like with the peroxide, expect that they could be, in a little bit of pain at home, and then see what the reaction is. And if they look at me like I'm crazy, then we're going to just start with Ciprodex or Floxin and, see how they do. Every once in a while, I'll have a family that's like, no, I want to try, what you think is going to be to maximize it. And so sometimes I'll do that. In terms of, papoose.
Before you move on, for the peroxide.
Yeah.
So do you have a thought about whether it's clogged with like what looks to be like mucus from the middle ear or some sort of like crusting versus like a blood clot? Like have you ever looked in there and you see like a blood clot that's probably from surgery?
Yeah.
Like, do you feel differently about
that's it? Yeah, no,
how you would treat it?
That's a great question. So in terms of the blood clot from surgery, that's definitely, I think, where the peroxide probably is going to give you the most bang for your buck. And that's going to be the kid that either is going to be your first post-op follow-up. Although every once in a while you might see it a little bit later on down the line because they had like a bad acute OM, otorrhea, that also had some bleeding. In terms of really thick mucus, it makes me think of my primary ciliary dyskinesia kids, or the kids that are like under 2 and they're still in daycare, or, they're just, 15 months and we're in the middle of January. They're going to keep getting those 6 to 8 colds a year. And it's like, well, dang, we just had, that otorrhea, 3 weeks ago, 2 weeks ago. Like, it's just, constant. And I, I'm not necessarily, I don't see it. And I'm not necessarily worried about cholesteatoma at that time. I'm worried about more of just these colds that keep happening. For my PCD kids, I will tell them to routinely do a little diluted peroxide and get one of those blue bulb syringes, the baby nose ones that flare out. I'll have them then kind of suction their own ear because the diluted peroxide kind of thins it because it's thick. And then they can get one of those blue bulb syringes. I'll tell them it's going to flare out. So it's not like they can shove it in too deep to their ears, but I'll have a mark from the tip about 7 millimeters or so, and then gently squeeze the bowl, put it by the ear, and suck it out. Because otherwise, those kids are constantly in my clinic getting papoose, especially, the 3 to 5 year age. And at a certain point, they're not going to let you even look in their ears. So this is something that maybe would avoid that, because overall the thick stuff's gone, and then they can get the drops in. And so sometimes I'll have them do that a couple of nights a week, just depending on, or even, once a week, depending on how much they get, because it's just oral toilet for that population. And so those are the two that I tend to be a little bit more. And then if it's like mucoid, thick stuff that's blocked, I might just, I'll talk to the family every once in a while. If it looks like it's worth papoosing and suctioning, I might do that versus trying some drops if I can see the tube and think the drops will go in, and have them come back. And if that still didn't do it, maybe try to see if it's loose enough to suction out the second time around. In terms of a pick and trying to do, wax in the lumen, that sounds lovely. And it just depends on the kid and what I think is actually feasible. But that's not a part of my routine practice, I'd say. Sometimes they're big casts too, right? Like you've taken the tube out and it's a whole cast that's 2 millimeters or something, which sounds kind of small, but it isn't. And it's hard. And, that's not always.
I feel like that's in in adults. I feel like that's kind of what I'm picking out a lot, is like this little cast that's like some old, drainage or mucus or something that has kind of just occupied the lumen long enough that it just stuck there. And usually I can take like a little rosin or something and just kind of slowly pick it out.
Do you do peroxide and let it sit and soften it and then suction and pick, or does it tend to kind of work its way out?
It tends to work its way out. I don't usually put anything in there. It's all patient dependent too. Some patients just really don't tolerate you kind of flicking the, because you're gonna touch the tube a little bit. But those tubes, I think that silicone material doesn't adhere to it very well, so it tends to kind of come out pretty. Like if you can kind of get an edge on it and gently just tease it out, it'll slide out. But sometimes if it's like wax or something that's been pushed down there with a Q-tip or something like that, sometimes I'll do some baby oil. But again, I don't want that going into the middle ear. So it's only if the tube is really clogged and the wax is hard enough that I'm not really able to get it out with other instruments, and I just really need to soften it up. Baby oil is really good for that.
And and they're in the clinic, in your chair, you do a couple of drops of baby oil, let them sit for a little bit.
Yeah. And then just kind of try to suction it out or tease it out. And then, but I've pulled out a tube before.
Yeah, I was going to say
that's
too.
Also, that happens.
Yeah. Well, I guess in your clinic, an adult, you can just put a new one in.
Exactly. That's what I've done. If it comes out, it's like, oh, whoops.
Yeah. I think
can we get another tube?
Yeah. And kids, because most of the time there are people that do tubes in kids in the office with the, what is it called? The
hummingbird.
The hummingbird. I always want to call it the butterfly, the hummingbird. But, for me in my practice, I usually end up going to the OR. And so the question is who, when, and why are we going? Because if we just put the tube in, it always kind of makes me so sad that we're back 3 or 4 months later because it's clogged and they're still having ear infections and it's OME and we're still requiring orals or, affecting hearing or speech. And so that doesn't happen often, but when it does, I'm always like, ugh. Okay,
it's a bummer.
Yeah.
How long do you wait? And what's your follow-up? So let's say you see a kid and they've got a clogged tube that you just put in, 6 weeks ago, 3 months ago, whatever it is. Are you going to, try some things and bring them back every 2 to 3 weeks? And then, if you're not making progress at some point, go back to the OR? Or what? I know that's not a clear-cut answer for everyone, but kind of what's your thought process around that?
Yeah. So I used to be like, I'll see you back. It depends on how, obviously, like we said, if it's otherwise hearing, good sound field or good audio, type A temp, it's functioning normally, I might just see back in 3 to 6 months for a regular tube check. I don't get too crazy, and I tell the families, hey, if we're back in the same cycle of recurrent ear infections, or if there's hearing or speech concerns or chronic fluid, come back and see me sooner. If it's the kid where, hey, we had tubes 6 weeks ago, the other side's draining good, the, side that's clogged has OME, I might do more of a 4 to 6 week follow-up, because that gives me a little time to see, are we still in the same habit of infections again? Am I giving that ear eustachian tube an opportunity to clear? Sometimes I'll do like 6 to 8 even, because I have to remember, like, every visit is time off from either work or having to figure out, childcare. It's a lot of visits otherwise.
Yeah.
And it's different than chronic otorrhea, or not chronic otorrhea, or otorrhea that just doesn't get better.
Right.
Which does
Are you having
require...
them use drops that whole time?
No, I might just do it for like 10 days or something like that and see how they do. And then kind of give them an opportunity to see, does it clear on its own? Like the fluid in the middle ear clear on its own? Does the eustachian tube get any better? Are we back in ear infections again? Just because otherwise I'm going straight back to the OR. And I know it's only a 5-10 minute, but every time it's still like, okay, I want to make sure that it's worthwhile.
Yeah. And a lot of times it comes down to like how worried are we, right? Like what's the risk benefit ratio, and what are we really treating?
Yeah.
Because it's easy to like want to treat the tube.
I want that large volume blue tip.
Yeah. You want to have
that everything's
pretty,
open.
patent, tube that's functioning and ventilating the middle ear really nicely. But I sometimes I have to remind myself, wait, the kid's doing fine. Don't worry, just because the ear doesn't have that pretty textbook picture. If the kid's doing fine, then there's time.
Yeah. So, which makes me kind of ask, what are your thoughts? So the new ear tube guidelines came out, and one of the changes is, not routinely using antibiotic eardrops at the time of ear tube placement. I think there is some flexibility in the language, right? Of, obviously if it's pus or something, you'd probably do Ciprodex after. But after placing the tube, is it worth still doing the Ciprodex? And the recommendations are no. What do you think? Yeah. I mean, they just came out. I haven't changed my practice yet. I tend to do Ciprodex still.
So I've been doing this in adults for a while now, because there was a point when Ciprodex got really expensive and it just didn't make sense to me. Like, if at the time of tube placement, if the middle ear looked healthy and not, inflamed, I wasn't let's say, I went to suction and it was dry. This might be for these patients who have occasional eustachian tube dysfunction related to flying, or, maybe they just have, some issues equalizing the pressure in their ears, or, so meaning, the tube is for kind of some intermittent eustachian tube dysfunction. And so at the time of tube placement, they don't really have pathology in the middle ear. And it doesn't make sense to me to instill drops if it looks normal.
Yeah.
So I've kind of been in that habit on the adult side for a while, and everything's been okay. I still send them with a prescription for Ciprodex and say, if you have otorrhea, you go pick this up. If you have, pain or something that seems like you have an ear infection, then start the drops. So yeah, I think that makes sense.
Yeah. I think it makes sense. I have to start figuring out how and when I would use it in my practice. So I think for let's say the kids that are, recurrent OM, I think with the guidelines that came out, I can't remember, maybe 2011, where it's yes, you have the number of ear infections 3 and 6 months for a year, but fluid on the day of the ENT visit. So that when you take those kids to OR, I think it's still probably 50-50 whether they're going to have fluid at the time of that ear tube or not. And so I guess then it boils down to, is there fluid at the time of the tube? Is the fluid a lot or a little bit? Is it purulent? Do you have a lot of bleeding? Whether it's just the myringotomy and the drum's inflamed to, hey, my canal got a little dinged and there's some bleeding. Yeah. And I think I have bleeding when I put my tubes in. There's always something, right? There's a little bit.
Yeah. If
so
there's bleeding, I think I would use drops.
Yeah. And so then the question is, so, I have a colleague that does some Afrin, and maybe where if it's just a little bleeding or maybe a little bit of mucoid fluid, but doesn't look purulent and you felt happy with overall looks clinically healthy, the drum in the middle ear, are those alternatives okay? Or do you really not need to do anything? And so, I feel like I'm out in my practice long enough to where, I'm like, oh, what? We're changing up my routine. Whereas like 10 years ago, right, we stopped doing antibiotics for tonsillectomy. We stopped doing, narcotics. And of course, that's just what it was. That's what I did. And now I'm like, wait, what?
Yeah.
So, but yeah, I appreciate the fact that the guidelines are there because the cost of drops can be exorbitant. And if you're, depending on where you're putting the tubes in, whether it's a hospital setting, an outpatient surgery setting, those charges can be exorbitant. And so in terms of practical purposes and what's actually indicated, I think it's helpful.
Yeah. I would say if I'm suctioning any fluid, if there's an effusion and I'm suctioning anything, whether it's like serous mucoid purulent, I'll probably use drops.
Yeah.
I don't know. That's my gut reflexive answer. And if there's bleeding, I think I'd worry more about, the tube getting clogged with like a, blood clot. But, like trying your trick with the half strength hydrogen peroxide, maybe it's do a little Afrin at the time of surgery. And then if they come back with it clogged, then you could do the peroxide. But I don't know. I just, you just feel so bad when that first post-op visit, you look and it's a clogged tube, it's just kind of like, ugh. Yeah. So.
Can I blame the tube on that one?
And whatever you can do to prevent that from happening, like you kind of, I guess it's just always about weighing the risk, benefit, cost, all that kind of stuff.
Now, a quick word from our sponsor.
Buying a home like the one I grew up in has been my dream. We had this great yard where my brother and I would run under the sprinklers. We had a big kitchen table where I told my parents I got into med school. Now I'm a member of Laurel Road for Doctors, where I got a great rate on a physician mortgage and was eligible for no money down and no PMI, so I could make new memories in my own home.
Laurel Road for Doctors. Banking, insights, and benefits uniquely designed for doctors. See laurelroad.com/doctorhome for full terms and conditions. Laurel Road is a brand of KeyBank N.A. and Equal Housing Lender. NMLS 399797.
Now, back to the show. All right. What do you do about tube otorrhea?
Ciprodex is probably the first most common, thing, like where that's so common that, even when patients call, most of the time the nurses will just check and be like, I'm sending in some Ciprodex. And I'll be like, yep, that sounds great. Let's try that first. So, I would say, I don't know, what percentage would you say? A significant part of the time that's going to clear it up and help. And I always tell patients to do like a pumping the tragus. So, putting a finger on the tragal cartilage and kind of pushing in and letting go, pushing in, letting go to try to drive those drops down to the drum and through the tube. I know the otologists have always told me that's important. And so that's kind of my first go-to. If they're in the clinic, I like to try to suction as much as I can. Because if there is a bunch of really thick stuff down there, maybe the drops can't even get through the tube and where you want them to go. So getting it cleaned out as much as you can to allow for the drops to get there, I think it can be helpful too.
Yeah.
What about you?
So if I can see the ear tube and there's just a little bit of drainage on the drum, I'll just have them start Ciprodex. This is if I've seen them in clinic. Obviously, if I can't see the tube at all because there's so much otorrhea, we're going to suction and it's going to require papoose. And I always tell families at the time of surgery before we do the tubes, and that one of the things, especially in kids under 2, otorrhea and having to be papoosed and getting suctioned, or otorrhea, and that might be on more than one occasion sometimes, is a very real part
so
of your
prepare them
post-op.
that.
I do.
Prepare them for that before surgery.
Because as a parent, that it's kind of a, even it's 5 minutes, we're burritoing their kid and it's loud. It's, the child is screaming most of the time. Yeah. And you may have to do it more than once. It may not resolve the first time around. But usually that's kind of when I decide to suction. Most of my kids that are primary ciliary dyskinesia, I just suction them every time, their ears, depending on the age and their tolerability. So I have a handful of younger PCD kids that I just can't do it every time because they're not going to let me look in their ears. And those are the ones, as long as I can see the tube and their audios are good, even if there's a little fluid just kind of by the tube, that's actually a good outcome.
Because it's coming out. The fluid's coming out.
And then the patients that are a little bit older, who I've known now for a couple of years, they come in, they, understand how what their pathophysiology, why and what's happening. They're a lot more amenable to it, and they're used to it now.
What size suction do you use?
In my kids that are under 5, under 3 to 5, I use a 5 suction usually. For the lateral canal, unless it's just so thick, then I have to start with a 7 in the lateral canal.
Yeah.
And then, but what I like with the 5 is then I don't have to necessarily switch over to a 3. I can at least get it so I can suction, see my tube, see the lumen, and get anything thick. I mean, they're not going to let me get in with a 3 and get it, we're just trying to make sure the drops go in. For my older kids, again, if it's thick, I might have to start out with a 7 for that lateral canal and then go to the 5 usually. So that's kind of how I do it.
Do you ever put anything in there, like in clinic, to thin things out before you suction?
No, not necessarily, unless I'm worried the lumen's clogged.
Yeah. And I mean, they're papoosed and you're on the clock and it's like, all right, let's just.
Yeah. Not my older kids though. I can't papoose. Once they're like, 7, 8 years old, it's a little, it's kind of, it's like under 5, you might be able to, Okay. So let's say they come in and it's still, you've suctioned their ears, you dried Ciprodex for about a week, but they're still having otorrhea.
So we'll take a look. Sometimes with Ciprodex, you can get some clumping, like the medication will crystallize and you'll get this like white clumping down on the tube or on the drum that sometimes will continue to clog your tube. So you have to be mindful of that. So you may have to clear that, under the microscope in the office. If they're continuing to have just nasty drainage despite being on Ciprodex, sometimes I will have them come back more frequently to where I can suction them more often, because the thought being like, okay, maybe the medication is not able to get through the tube and into the ear to treat that mucosa because there's just so much drainage and they just need to have more suctioning, more often. But, I've never tried the blue bulb trick that you're talking about with your kids. So maybe I'll start doing that in adults and see if that helps, just to give them a way to kind of clear some of that so that the drops can get down to the drum and through the tube.
I think that's only really helpful for that thick lateral stuff.
Okay.
Yeah. But at least some, you know what I mean? It still, I think, helps. It's something.
Yeah, for sure. Especially if patients have drainage that's coming out of their ear onto the pillow, if you're dealing with like a large volume.
Yeah.
Let me think. Sometimes I'll switch up the drops. If in a patient who has really bad allergies or, maybe is like a chronic sinusitis patient, sometimes I will switch to just a steroid drop, like dexamethasone or Predforte, with the idea that, the middle ear is like a accessory sinus. And so in the same way that we, use Flonase or Nasonex or some sort of nasal steroid in the sinuses, you're trying to apply some steroid into that middle ear space. But again, you need to be the tube needs to be open and working so that medication can get in there and treat those surfaces. Sometimes I'll use some mastoid powder. You have to be careful with that because it can clog the tube too. But I have had a little bit of success doing a little bit of puff of that in there if the ear is just really wet and really draining a lot and you need something to kind of help absorb some of that. I don't know. What are your thoughts?
Yeah, no, I'll probably see them back a little bit closer in follow-up compared to the clogged tube one. I might say 2 to 3 weeks. And a lot of times if it's still significant otorrhea, that patient's going to be back within about a week or so. Or that too, sooner rather than later because they can see it, right? And I'll suction again, and I might try some mastoid powder at that point. But you're right, it's different than just like a perf that keeps draining or an otitis externa that just won't dry up. And so you're right, that can get clumpy and it can clog the tube as well. And so sometimes I'll do the mastoid powder and then maybe let that sit at home for a couple of days and maybe even restart something like Ciprodex or Floxin a couple of days later, like maybe 2-3 days later to kind of clear some of that. But I guess at some, I don't do this a lot, but I've had a handful of kids where it's like we've been doing this now for 4 to 6 weeks and it's just still, and every once in a while I might add like Augmentin or something. I know we're always like, tell the pediatricians not to do oral antibiotics when you have tubes, but every once in a while, it's just, you've already maybe brought them into clinic, papoose and sections 2 or 3 times, and we're still doing this. And I more than some sort of, it's catching, the one virus after, you know what I mean? Maybe they caught something else 3 weeks later and here we are again. And so every once in a while, do we have to do that? It's not common, but something that I'm like, well, I guess, what else can we try? I like the steroid drop. I haven't done that as much in my kids, but maybe my older ones, where it's more allergy related, makes sense.
Yeah. What are your thoughts as far as, thinking of the otorrhea as a good thing in that, having the tube there means that all of this fluid isn't stuck in the middle ear and it's able to come out. And yes, that's annoying and you're seeing
I love
it,
that
but,
idea.
What about that reframing? Do you ever have that conversation with your families?
Absolutely. So I actually had that recently on clinic a couple of days ago. And it was probably the baby about 15 months, had ear tubes about maybe 6 months ago. And mom was a little nervous, like, hey, we've been on ear drops 3 or 4 times in the last 6 months for drainage. And I'm like, and when I look in the ears look great. Fortunately, they weren't wet or draining on the day of the visit. I'm like, that's a good thing. They're working. This is, these are, because of the tubes, have you had to be on any oral antibiotics since? And they're like, no. And I'm like, this is, and at the time of consent, I say that the tubes aren't going to make the ear infections go away. But hopefully they're less frequent, although sometimes, they still get those 6 to 8 colds a year and they may still have drainage with all of them. Or hopefully they're less and less frequent and less severe. So they're not fussy and crying at night and not eating, not sleeping, hopefully not fevering, things like that. And so I think that the expectation of what the tube is there for should be set up front. That it's not all of a sudden the infections are going to go away. It's just we manage them hopefully differently and in a more tolerable, easier for the child and the family. But yeah, the reframing is very important.
Setting those expectations and what to expect, and for sure.
All right, what do you do with the tube that just hasn't fallen out? How long do you wait to consider a retained tube in the middle ear? Obviously, we're not talking about the external ear, but middle ear. What do you
it's still in the drum, or it has
sorry, not medialized. I meant in the drum. Sorry.
So in adults, I try to just hold their hand for as long as I can and just say it's gonna come out. Because I feel like it's we put tubes in the clinic all the time, and it's relatively easy. In adults, it's a little harder. It's a lot harder to take them out to kind of reverse that because there's not a great way to anesthetize the drum. It's kind of like a 1, 2, 3 pull kind of thing, which is uncomfortable. I suppose you could always go to the operating room to take it out, which I've done on a very rare occasion. So that's not super common. So yeah, I mean, for me, it's a lot of just like, well, let's just give it some more time. Let's give it some more time. And in most adults, it's not causing issues. Like if it's still there and it's still open, like unless, so like, for example, maybe you have that patient that's wanting to learn to scuba dive this summer. Yeah. And they really don't want, they can't have that hole in their eardrum. That might be, one example of a patient that you may need to speed it up. And I don't know. I don't have any tricks other than I would say you probably have to just take them to the operating room and pull it out and maybe put a little paper patch or something.
Yeah.
I don't know. What are your thoughts?
So I take it out in clinic now because it's a papoose. So first I'll see if it's been about 2.5 to 3 years. That's when I start to prep the family so that it's not like, because I just don't want the child to end up with a perforation. To me, that's a bigger headache. I'd rather have to go back and put a tube in because we, took it out and they're still having issues. But usually the other ear will have declared itself, right? of whether the eustachian tubes are working or not. And so if we've gone 6 to 9 months without having any issues in the ear where the tube has fallen out in terms of fluid, infections, things like that, and the other ear that does have the tube in the drum, and now we're getting to 3 years, I talked to the family. Most families don't want to do the general anesthesia for this. And if we can papoose the child, it's a Band-Aid, right? It's a quick, like you said, and the kids cry. The kids cry. But, families, I find that most families are okay with doing that. Now, if I can barely get the otoscope in the kid's ear, as a family, if the mom or dad are like, I sit down and explain it to them. Like, listen, they're going to feel this, but it's a quick Band-Aid. And we do have to burrito them, and the child is going to cry a little bit. And if the family's like, no, we'd rather go there, then that's where we're headed. And obviously, I'm not doing like a patch or something at the time of. We're just getting the tube out. If I can get another quick look to see about the hole and if there's bleeding, that I've called that a great, great success. To get to
look
because every
at
once in a while you
after
can't even
pull,
look afterwards. You just got to get them out,
Right.
and then I'll see them in about 3 months and see where we are and things like that. And so that's what I've
most of
been
the time
doing.
it just heals up fine.
Yeah, most of the times it does. And then if we have to go back and do something because it's now been several months, or hey, the perf is now causing issues with hearing or otorrhea, that changes the game a little bit. Yeah.
Maybe I need to talk to my adults about the 1, 2, 3 pull.
I used to be a lot more hesitant, but I got to talk about Ron Mitchell every episode. Dr. Mitchell, hello. He just does it in clinic. So I'm like, well, man, if Mitchell can do it in clinic, then come on, let's do it, So if the boss is doing it, then,
Yeah, I bring it up to patients as far as like, we can take it out. It hurts a little bit or maybe a lot. I don't know. I haven't experienced it myself, but I think in a lot of them, if it's not an issue, it's just like, okay, that's fine. Like, we'll just wait. Adults, it's a lot different than kids, I feel like. And so we just give it a little bit more time, and most of the time it will fall out eventually.
Yeah. What about granulation that starts to form around it to IS?
Oh man, that's such a pain. Well, we got to talk about that. So when I see that, sometimes I'll just try to start some sort of steroid drop. Sometimes, depending on where it is, if it's, blocking the lumen of the tube, I will try to like grab it with some cups and try to like kind of debulk it, or,
it's going to bleed.
It will bleed.
Bleed.
Yeah. It bleeds. I spend, another 15 to 30 minutes messing with it and suctioning, and it can be a real headache. Yeah, I don't know. I would love for you to share some pearls.
Oh God, I wish I had some pearls.
Tell me all your secrets.
Yeah, right. So I think that when it's sort of around or coming through, I definitely, if there's drainage, I'll try to suction. If it's huge, I might try to remove it. Ciprodex. For those, I might even do oral antibiotics to cool it down. The one thing with any sort of granulation or anything like that, I just want to make sure I'm not missing something like cholesteatoma. Sometimes that can be a red herring. It's not always. It might just be a bad infection, but those always kind of make me a little nervous, like, am I missing? So I really want to try to cool it down so that I can see if there's any skin, things like that. If the tube has been there a long time, over 2-3 years, and we're dealing with this, every once in a while, I might just take the tube out, maybe. I might try to cool it down first, see how they look when they come back, and get it out, because it could be, now acting a little bit more like a foreign body type reaction. Also, kind of give me a better exam if I am worried about something like cholesteatoma. But yeah, those are tough, and they always, they're hard to cool down, hard to get an exam. They bleed. And then in the back of my mind, I always start, that's when my like, am I missing anything else? Kind of starts, So in those patients, I'll do, let me see back in 2 to 3 weeks and kind of make sure they know what I'm thinking about too, because I don't want them to be like, all right, bye. And then like, here we are with something else as an issue later on. But they'll usually come back because they're going to have symptoms from it or, something.
Yeah. One thing I meant to, that I was thinking of asking you earlier, the concept or the thought of like biofilms. And so like a patient having a tube, let's say it's been there for a while, maybe over a year, longer than it should, and the patient still has eustachian tube dysfunction, still needs a tube, do you ever, exchange it out? Or let's say, this is a common example. Patients had bilateral tubes. One tube has extruded. The other tube is still there. It's been there for like maybe over a year. It's fine. When you're going to the OR anyway, because you're going to put a tube in the other ear. So do you need to replace that tube with a new tube because it's an old tube?
Yeah. Those are great. Those are great questions. And it's funny because those are the conversations I have with the residents, right? Like, because this is the stuff they have to think about. Like, this is actual decision making in clinic, which sounds so simple because we think of just, it's just a tube, but like, it's not, right? So in terms of biofilms, I don't like to, so I think in pediatric, especially in kids that are young with tube otorrhea, if it just doesn't go away, before I go back and switch stuff out and that kind of stuff, I might send them to immunology. I might think of something else like sweat test, PCD, other stuff. CF doesn't have it as much in terms of OME, but PCD would. And just, like, what are we missing? Or is it just like your, kid that gets the 6 to 8 colds a year? And so I tend not to necessarily go switch tubes out for biofilms for those reasons. And I do think that, oral toilet is our best friend for that. Because if I put a new tube in, we might still be in the same situation afterwards because we're still 15 months and in daycare or not daycare, and we're just getting these. In terms of, biofilms for tubes that have been sitting there for 4 or 5 years in a PCD kid that I'm going to the OR with, if the tubes are working, I kind of want to leave those alone too. Like, I don't want I've had issues where, maybe we try to put a new tube in and it gets pushed out. You know what I mean? That's happened. And so I don't always do that. I know I keep talking about my PCD kids, but that's their issue. It's tubes, tube otorrhea. Yeah. And then in the child where, the left ear tube is out, the right tube is open and working, but the left ear keeps getting OME or acute OMs, and it's been a year. I talk to the family and I say, I guess my concern is I've had issues, one, where if I try to replace the tube, taking a good tube out can make the perf bigger, and then I can't get a tube in. That's happened, and that's really frustrating.
Yeah.
And then the second thing is, if I'm putting a new tube in, I have to remember that perf now has been there a year plus, however long that tube may be. So I don't forget about it because I don't want that child to end up with a perf after. And so I always tell him, like, if it looks good, it doesn't look like it's halfway out, it's not blocked, it's in a decent spot, meaning it's inferior or at 6 o'clock, whatever, it looks good. I hedge on leaving it alone and tell the family, listen, you might be, frustrated with me 3 to 6 months down the line because we may or may not have to go back. But maybe by then the kid is 2.5, 3, closer to 4. And I don't know, if it were my own kid, I'd rather go back for an ear tube than end up with a perf. I just, perfs to me in kids are just a much bigger issue, especially between especially under 5. I don't, whether it, not just otorrhea, but it's hearing, speech, difficulty in, whether they end up having to get a tympanoplasty, post-op care success rate, like that should be our next podcast. But
yeah.
So that's kind of how I phrase it. Now, I know, I have partners that, routinely switch them out just because it's like, well, we're going to the OR. But that's just my personal preference, I think.
Yeah.
I don't know.
Yeah, I've had that same feeling before where you pull out a perfectly good tube, perfectly good but old, we'll say quotes old. And then when you put the replacement tube in, that hole is just, it's too big, right? It's big. And so you're like maybe putting a piece of gel foam or something to just kind of give you some extra something to hold it in place because it just looks like it's just sitting there, kind of on the edge of a big perf.
Yeah, when you take a tube out, there might be a little wax on the drum. And so when you take the tube out, some of that squame, the drum comes with you, or, it just the bottom of the medial end of it kind of, and I like it. Like, I like that the fact that when you pull a tube out, it refreshens the edges, right? Like the act of pulling it out kind of is that sort of freshening it up for epithelialization. But man, and then you end up with something bigger, can't get anything in. And I've had kids that end up with perfs. I'm just like, ugh, gosh, why? So I don't know. That's just my personal opinion on it.
Yeah, but you're right. It's a conversation to have with the family, and that's, a lot of medicine is that shared decision making, and depending on the kid, maybe the risk of a second anesthesia event in 3 months is really a big deal.
Yeah,
and
absolutely. Maybe they're malignant hypothermia family history or cardiac kid or absolutely.
Yeah. So there's not one size fits all, right? So.
Yeah. Yeah. What is there? I mean, okay, really quickly, just a yes, no. T-tubes, no T-tubes. You don't have to do a yes or no.
Most of the time, no.
Yeah, I don't like them.
I don't like them that much. But in the right patient, it's there are some patients where maybe it's worth a try. Like I put in a T-tube the other day in a patient who she had she had a skull-based tumor that basically caused her eustachian tube to be obliterated on one side after her surgery and radiation, everything like that. So she basically does not have a eustachian tube on one side. It is always going to need a tube. And so we talked about, the benefits of having a T-tube and it being there, being able to stay in longer and blah, blah, blah. And the risk of it causing a perforation compared to like a smaller Pepperella tube or something like that. She's one of those patients who is a lot of anxiety with even just looking in the ear. And, so the idea, getting her to put a tube in clinic was a big feat. There was a lot of like hand holding and like talking her through allowing me to do that. And so it was just like the best plan was like, okay, this is potentially a one-time thing that we can do that will last us longer. Maybe it causes a perf. If it does cause a perf, maybe that wouldn't be such a bad thing because you don't have a eustachian tube. Yeah. If it causes some hearing loss, you kind of need hearing aids anyway because you've got some sensory neural loss as well. Yeah. It was a long conversation because as you're alluding to, like T-tubes are not my favorite thing because, I always think about, the times when I put in a T-tube and I see patients back in clinic and it's just sitting in a perf.
Yeah.
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 It's just
gigantic
like,
perf.
It's there, but it's just kind of got this spotlight on it. It's just the perf. It's just sitting right there. It's kind of cringy. Yeah. I don't know. What are your thoughts?
Initial gut. Yeah. I'm like, I don't like them. No. But I think what you describe as like, patient selection is probably the most important thing. I used to kind of be like, well, if it's been, more than 3 or 4 sets and they're 6 to 8 years old, that might be something to consider, and was a lot more open to them. But I agree. I find that they leave really big perforations sometimes. Usually those kids that are having that many sets of tubes have really thin eardrums. They're pretty atrophic. And so when you're trying to get the T-tube in, everything kind of tears apart, I feel like. And then I don't know how much of a service I'm doing. And so I tend to lean away from them. That being said, you do have a handful of kids that have had a history of radiation to the head and neck for, and so that might be somebody to consider them in. But, it just depends. I agree. But I'm pretty, that's one where it's a good conversation with we need to sit down because parents will ask, hey, I want those permanent ones. I want those, the ones that are the permanent ones. And, I kind of tell them, some of the issues that can come along with them. But yeah, I think there's a role, but it's got to be discussed and thought out, I think. So
yeah, for sure.
Yeah. Man, this was a very stimulating conversation on the management of tubes.
I'm impressed that we were able to talk about so much. I guess there's more to it than you
I was like, I don't know how we're gonna. Yeah, I know. And I'm sure there's other things.
For sure.
Yeah, if there's anybody out there that has more on the management of ear tubes or other common ENT things that, sometimes it's practice dependent, really, what you see. These conversations, I think, are great to reach out to.
I'm sure we'll get feedback from people about all the different ways these topics can be managed because it's one of those things that's just so common and probably depending on, where you practice and your resources and all those kinds of things, it affects, how you manage it. But good idea. This was great. All Shall we put a pin in it?
I think
Shall
this
we land
plane
this
is ready to
plane?
land. I think it is. I've been trying to say that in the prior ones. It just doesn't sound as good. Ash, I'm going to leave that to you.
Well, it's been a pleasure. Always a pleasure to spend my weekend mornings with you.
Likewise, Ash. Likewise. You can find us on SoundCloud, Spotify, iTunes, Apple, and Ghana. Please follow us on Instagram and Twitter @_BackTable ENT. We love feedback. Reach out to us for topics, ideas, speakers, if you ever want to come on the show. And I think it's a wrap, Mamacita.
Like us. Yes, that's a wrap. Like, subscribe, share. That's a wrap. We'll see you next time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.